This conference will now be recorded.
Hello, everybody. I hope that you all had a very good week and that you have done the reading because that's very important to go along with the lectures. Some of this lecture will be in the book, and those are the areas that I focused on in your reading in the book. And then the other chapter will focus on other important information. So again, anything in this lecture can be on the quiz as well as the reading that I told you to focus on. Again, just focus for this quiz, just focus on reading what I told you to read, as mentioned in my email to everybody. So today we're going to be talking about neuroendocrine system disorders. And the disorders that will be related to the endocrine system. And this is important in psychology because you will catch a lot of things that may appear to be psychological when it could be something related to the endocrine system. And that's important. A lot of therapists or psychologists aren't trained in this aspect, and based on my training in medical psychology and health psychology, this is a big piece that we focus on. And oftentimes, many patients will go into treatment or clients and they'll be presenting with severe anxiety, severe depression, and and the therapists don't assess medical as well. And I've caught a lot of illnesses, especially around the thyroid, um, where it was the thyroid and not an organic sort of depression or anxiety. And once they were appropriately medicated with their for their medical diagnosis, for example, with the thyroid going on levothyroxine, the brand name Synthroid, once they stabilized out, that depression went away. So it's very important part of psychology to understand these pieces and what we've been talking about so far. So the first thing that you want to be aware of is the pituitary. The pituitary is very small. It's the size of a pea. So it's approximately a half of a gram. And it's the master endocrine gland. And the reason why we consider it the master endocrine gland is because it releases hormones that will activate the other endocrine glands. So there are specific, and we'll get into the specific sort of hormones that the pituitary will release to activate other endocrine glands. And then those endocrine glands will release neurotransmitters or different sort of hormones or whatnot that are separate from the pituitary uh, that will help with bodily functioning. So the pituitary, it's located at the base of the brain, so it's at the bottom of the hypothalamus. And in general, our endocrine system functions are for sex, metabolism, nursing, salt and water concentrations, especially with the kidney functioning. So there are a lot of different components of the endocrine system that function for various reasons. Now, with the pituitary, the hormones that are involved specifically with the pituitary, um, the first cluster being somatotropins. Somato, you think of body, okay? Somato, you think of body. And when you think of somatotropins, you want to think of growth, so body growth. So one of the somatotropins is our human growth hormone. On blood work, you'll see it as HGH, and this is released, the somatotropins are released by the pituitary, which you'll see later that relate to growing. And we'll talk about what happens if it's low levels of somatotropins or high levels of somatotropins. But what I want you to remember is somato meaning body. Somatotropins have to do with growth, our body growth. Now, thyrotropins, how you're going to remember this is that this pituitary hormone, the thyrotropins, are going to be related to the thyroid. So you see thyro, think thyroid. So if I asked you a question on the test that said, which of the following does the pituitary release to stimulate the thyroid? You are going to say thyrotropins. Now, one of the thyrotropins that we see with the pituitary is our TSH, and this is often tested in your annual blood work to look at the pituitary and how it is stimulating the thyroid. Okay, so you're going to learn later about thyroxine or thyroxin. That is specifically with the thyroid that the thyroid holds and releases. But the thyroid stimulating hormone or TSH is a thyrotropin, and that's related to the pituitary. So the pituitary has to release the thyrotropin to stimulate the thyroid gland, and then the thyroid gland will release thyroxine, which we will talk about shortly. So the next are corticotropins. Corticotropins released by the pituitary and are one that we think about. If you think of cortico, think of steroids. So you hear about corticosteroids. So pituitary releases corticotropins. Adrenocorticotropin hormone, ACTH, is involved with stress. It's our stress response. So you could think adrenal system. So when we are responding to stress, our adrenal system kicks in. That is a corticotropin. So ACTH, it is involved with stress response to the adrenal system. That is a corticotropin. So again, these that I'm talking about are released from the pituitary. We'll get to the point where we'll talk about these glands separately, what they release, but know that if I say somatotropins, I'm talking about HGH or human growth hormone, and that is released by the pituitary. If I talk about thyrotropins, I'm talking about TSH, and that is what the pituitary is releasing to stimulate the thyroid. Corticotropins, I'm talking about what the pituitary is releasing to stimulate the adrenal system, which is going to be ACTH or the adrenocorticotropic hormone, and that's related to stress. Lactotropins, these are released by the pituitary so that we can have what's called prolactin. Now, in women and men, you may see this, not just women, but this has to do with breast milk or breast growth. Okay, so lactotropins are released by the pituitary, one of them being prolactin or PRL, and that's going to be related to breast milk or breast growth. So how you're going to remember this is lactotropins. You're going to think of milk, lacto, lactate, lactose, right? So lacto milk. So that's how you can remember it. The next group are gonadotropins. So these have to do with gonads. Okay, so the pituitary releases these gonadotropins, and the first one is the follicle stimulating hormone or FSH. This helps in women to control the menstrual cycle and also production of eggs. So oftentimes when individuals are trying to get pregnant, they can look at their hormone levels looking at FSH. The higher the levels, the better the likelihood that they are producing eggs and that they will get pregnant. FSH is also related to men in the production of sperm. So FSH can be looked at in men, higher levels, higher likely of conception. The next group is what's called a luteinizing hormone, or LH. This is different because with the follicle stimulating hormone, that has to do with production of eggs or production of sperm, right? Luteinizing hormone, or LH, is going to take in women those eggs now that they've produced and help them mature, help them develop. So it's taking it to the next level. In men, the LH is going to help with production of testosterone. And as we have more testosterone, we're now going to take that production of sperm from what FSH does, and we are going to help the sperm grow and develop. So when you think of follicle stimulating hormone, or FSH, they're helping to produce eggs or produce sperm. LH, on the other hand, or luteinizing hormone, that's going to say, okay, we have the eggs or we have the sperm. Now we need to help them mature and develop. Okay. So what happens with disorders? Well, with hypopituitarism. So hypo means low. So hypopituitarism, there is a low secretion or under secretion of growth hormone. So that human growth hormone is low. Now, in infants and children, we'll see hypopituitarism display itself with dwarfism. In adolescence, you're looking at delay in puberty, especially. However, in adults, it can happen too. So they could be going through life and their HGH is, or the human growth hormone, is fine, but then in adulthood, it kind of drops. And in this case, people who have hypopituitarism in adulthood can have impotence, infertility. It could lead to hypothyroidism, because one of the things about the endocrine system is everything is linked. So if some people are having difficulty, say, with the pituitary, that can affect other parts of the endocrine system. Now, psychologically, what can happen for infants and children are peer pressure. Dwarfism, they get picked on a lot, delays in puberty, they could get picked on a lot, they can have low self-esteem. So these psychological effects can occur in adults. There could be depression, there can be, because of impotence, because of infertility, there could be anxiety over those issues. Especially if they're really wanting to have a child and they're infertile. There could be a lot of stress, depression, even suicidality. There's been a lot of cases where people really, really want to have a child and they can't, and they specifically don't look at adopting or other options because they think it needs to be genetic based. And so this could be another issue for adults. Now, hyperpituitarism. So hyper means high, okay? So that's going to be the opposite. So in infants and children, you'll see gigantism. They're 7, 8 feet tall, very, very, very tall, because there's a lot of growth hormone. In adults, so say they go their life without hyperpituitarism, and in adulthood, they now have these symptoms of a whole bunch of HGH. They can have what's called acromegaly. And if you search that online, it's interesting because their hands, their feet, their extremities, they'll get very large. So they'll have very large hands, very large feet. And so acromegaly is what can happen in adulthood. Now, with the thyroid, the main hormone produced by the thyroid itself, not by the pituitary, because remember, the pituitary are going to be your thyrotropins, like TSH. However, with the thyroid itself, the main hormone we see is T4, which is thyroxine or thyroxin. You'll hear it both ways. So this is the main thyroid hormone. So if on the quiz I say, what is the main hormone produced by the thyroid? You're going to choose thyroxine, not thyrotropins, not TSH, because thyrotropins or TSH are going to be from the pituitary. I may even say on the quiz, which of the following hormones are released by the pituitary to stimulate the thyroid? You're going to pick thyrotropins, or if I say TSH, not thyroxine, because thyroxine is specific to what's held in the thyroid and is released. Now, this contains iodine. So a lot of time when they are doing tests to figure out how the thyroxine is being released, is it too much, is it not enough, they will use iodine in the blood. So they'll give them an IV of iodine and do the scans to see how iodine is reacting. So if you ever see that, that's why, because thyroxine contains iodine. So if they inject iodine, it's going to light that thyroxine up. The thyroid is very big with metabolism of carbohydrates, fats, proteins, electrolytes. Very big. It's very big with reproduction. It's very big with building immunity to infections. And we'll talk about that shortly. So very involved with metabolism. Now, where do we see dysfunctions of the thyroid or disorders? Well, hyperthyroidism. Hyper, again, means high or overactive. And when this happens, the person is producing excessive amounts of thyroxine. So what's going to happen? Well, if it's related to metabolism, it's going to speed up metabolism. So you can think of yourself as if you had an overactive thyroid or hyperthyroidism, think of it as if you jump on the treadmill and you start running. What's going to happen? You'll get heat. You'll get rapid heart. You might get a little irregularity with the heartbeats. But people are sensitive to heat. They will sweat really easy because their body is accelerating in metabolism. They can get anxious or shaky, nervous, difficulty sleeping because it's keeping the body metabolized. And so they may have tremors, impaired memory, irritability, agitated depression. So they have this sort of like depressive episode, and now they have that agitation with it. In severe cases where it's super high, a person can actually experience hallucinations and delusions, and it's scary. So some people may also get fatigued or weak. So the key pieces of hyperthyroidism, if they have too much thyroxine going on, think of jumping on a treadmill, sweating, rapid heart rate, anxiety, nervousness, tremors. The big thing, sensitive to heat. So when I see a patient come in and they're sweating and they say that they're very sensitive to heat, that, the temperature is set at 68 and they're sweating, or they feel very anxious and they think they have an anxiety disorder, I'm automatically looking at the thyroid thinking maybe they have a rapid um, or a high or overactive thyroid. So some of the psychological diagnoses that can inaccurately happen where they're diagnosed with things that really it's medical, being hyperthyroid, could be bipolar because of the highs, the anxiety, the lows, if they get the fatigue, weakness. It could look like psychosis with the hallucinations and delusions. Um, so sleeping, sleep apnea, there could be a lot of different things that may get diagnosed psychological when really it's physical. So we always, always, always have to rule out any type of physical issues before ever giving a psychological diagnosis. It's so important. Every client that comes into me, the first thing I ask them is, when was the last time you've had routine blood work? When was the last time you had a physical? And what are your medical conditions, or is there anything that you're at risk for? Because we have to rule that out before going psychological. Because if the person has, say, hyperthyroidism, and I'm starting to treat them for anxiety, it's not going to do the job. It's not going to work because they need to stabilize that thyroid in order for those symptoms of anxiety to go away. There's only so much I can do. Same thing if they got diagnosed with psychosis, it could be their thyroid. And so they may be given an antipsychotic, which are very, very heavy meds, or they could be treated for hallucinate, even hospitalized. And really, it's their thyroid. So keep in mind, it medical has to always be ruled out. So hyperthyroidism, overactive thyroid, this means there's excessive amounts of thyroxine coming out, and we'll see rapid heart rate, sweating, sensitivity to heat, nervousness, irregular heartbeats. So very, very important to look at. Now, you may have heard of Graves' disease. This is one of the diseases related to hyperthyroidism because there's many different types of hyperthyroidism. And so one of the most common that we see is Graves' disease. There's too much thyroxine. And what's happening, and the reason why there's this overproduction of thyroxine with Graves' disease, is that there are these antibodies that are attacking that thyroid gland, and what's happening is it's now going, uh-oh, I need to respond, the thyroid, and it starts producing a whole bunch of thyroid or thyroxine. So it's dangerous with Graves' disease. So with Graves' disease, not only does the antibodies attack the thyroid, but it also attacks behind the eyes. So oftentimes you'll see people that have protruding eyes, and they call it Graves' ophthalmopathy, where they have that protruding eyeballs. They're big. They look like they're sticking out. They're swollen. They're inflamed. They can have double vision or blurry vision. And that's because these antibodies are attacking the thyroid and also behind the eyes. You can Google some pictures, they're pretty gnarly. Um, but oftentimes I'll see people and I can tell and think, all right, they have Graves' disease. So Graves' disease is only one potential thyroid disorder related to hyperthyroidism. There are others, but just know Graves is one of the most common related to hyperthyroidism. Now, on the other hand, hypothyroidism is an undersecretion of thyroxine. So hypo, low. So what happens is the opposite of hyper. So people will be sensitive to cold. So it may be, say, 80 degrees in the house and they're freezing. They'll have dry, very dry skin can happen, dry, pale skin. They can have hair loss, depression, decreased libido. Because of the drying out, they could have muscle aches and cramps, memory impairment, fatigue, and weight gain. Hyperthyroidism, where they have over secretion of thyroxine, they often lose weight, and so they're very, very skinny. Hypothyroidism, you'll see weight gain because it's lower. It's an under secretion of thyroxine, so everything's kind of lowered. So some people may get diagnosed with depression, when really it's the hypothyroidism. I've caught that a lot, especially in women. Um, and some people, if they're older, they may get diagnosed with a potential dementia because of the memory impairment. So again, we have to rule out all medical before we go psychological in diagnosing. Now, there's many reasons for hypothyroidism, but a big one is called Hashimoto's, and they call it Hashimoto's thyroiditis. Itis means inflammation. So what happens is this is autoimmune, meaning the body is fighting itself off. So it's fighting off the thyroid, and it's going to affect the entire body with people with Hashimoto's. It's pretty difficult. Um, so what happens is the um, the body is fighting off the thyroid, and when it starts to fight off the thyroid will inflame. So oftentimes people will experience tightening or pressure in the throat because the thyroid looks like a butterfly, and it's right at the front of your throat. And so with people with thyroiditis or inflammation of the thyroid, you can feel it. So what a doctor will do to test for this is they'll stand behind the person. They may stand in front, but it's better to stand behind the person, and they'll just take their fingers and they'll put it against the front of the throat. And the best way to do it is have the patient drink like a little bit of water while they're feeling, and they'll feel the inflammation. You can feel it without drinking the water, but oftentimes when they're checking it, you have to swallow so they can feel that movement. And so they'll tell them to swallow, or the best way is to give them a little Dixie cup of water, have them swallow it, drink it, and then they'll feel for that inflammation there. So Hashimoto's is the most common cause of hypothyroidism. There's other reasons. Um, so one of the issues now, why the hypothyroidism is occurring, is that because iodine is contained with thyroxine, what happens is when we take in iodine, it converts it into thyroxine. So in the person that um, has hypothyroidism, they can't convert that iodine into thyroxine. And so what it does is it kind of backs up and it enlarges the thyroid. So that's kind of where that's coming from. So I may ask you on the quiz, like Hashimoto's thyroiditis is related to what? And your answers may be hyperthyroidism, hypothyroidism, hyperpituitarism, hypopituitarism, and you're going to know that the answer is going to be hypothyroidism, right? Okay. Now, with the pancreas is important for secretion of insulin. So when we take in sugar, insulin is going to be released to balance it out to where we need to be. So what's related to the pancreas? Well, diabetes mellitus. So you'll hear type 1, type 2, you'll hear diabetes insipidus, but right now I want you to know that diabetes mellitus is related to the pancreas. It has to do with secretion. Type 1 diabetes, you'll hear also known as juvenile diabetes. There's another name you'll also hear it as well, which I'll talk about in a second. But what's happening with type 1? Usually it's diagnosed on average. It will show up with children on average ages 7 to 9. It could be later. Rare cases, it'll happen in adulthood, but usually, and that's why they call it juvenile diabetes, age 7, 8, 9 on average, this will come about. And what's happening is the pancreas is either under secreting or it's not secreting insulin at all, which is why they have to go on insulin. And so the other name for type 1 diabetes, besides juvenile diabetes, is insulin dependent diabetes mellitus, or IDDM, because they have to have insulin in order to survive. If blood sugars go too high, too much sugar in the blood, they can go into a diabetic coma. And if the sugar is too low, they can go into a diabetic coma. So it's very, very dangerous. They have to take that insulin. They're dependent on it. That's type 1. They have to have it. They will have diet modifications. They may have a pump. Technology has come a long way in the years. It used to be that they only can inject insulin. Now they have pumps where they fill this little tiny pod with insulin, and then that attaches, they inject it into their side, and then it connects to a meter, which can also monitor their sugar levels in an iPhone. But they have a separate meter, and then based on what they eat and carbohydrates, because carbs will create sugar when it converts, that they can give themselves X amount of insulin depending on what their intake was of sugar or carbs. So there's that. There's also they may also have to, type 1 diabetes, they may not only have to be on insulin, but they may also, depending on how severe it is or whatnot, go on also pill or oral meds as well. Now, what are some symptoms of diabetes? Well, we'll see frequent urination and thirst. We'll see weight loss, increased hunger, blurry vision, lethargy, confusion, sweating, shakiness, weakness. So high blood sugars or low blood sugars, they could experience these symptoms. Usually with lower blood sugars, they'll get very hungry, and they'll get very shaky, weak, and they can get confusing. With higher blood sugars, you will oftentimes see the sweating, the confusion as well, even lethargy as well. So they can, whether it's high or low, they can experience a lot of these symptoms. So there's many disorders that are associated with diabetes that can affect blood sugars, and blood sugars can impact based on depression, and anxiety and panic. So we want to treat a lot of these people with diabetes that have depression, anxiety, panic disorders, especially because it can impact their blood sugar levels. So if we can keep their psychological symptoms at bay, then that's also going to help regulate their blood sugars too. Now there's many different types of diabetes, but the second big one that you'll hear about is type 2 diabetes, or they'll say adult onset. What they normally do is they'll start off by treating it with diet, exercise. It depends how bad they are. But oftentimes they don't have to start off with insulin. They may never need insulin, but they may need to take oral medication to control it, depending on how bad it is. Eventually, they may need insulin. Maybe they won't. But that's why they call it non-insulin dependent diabetes mellitus, or NIDDM, or adult onset type 2. Those are the three names we see because they don't, it normally occurs in adulthood. And what will happen is same symptoms that they'll start to recognize, and you'll see it in the blood work, low sugar levels, uh, and so that eventually they'll try to manage it with diet and meds. So you'll hear some people say, I have borderline diabetes. That's because they're right on the cusp. So it's by knowing that you want to control diet, you want to control that via exercise, and really, really try to do that before you go into full-blown type 2 diabetes, because then you're looking at even more treatments, including meds. So diabetes insipidus is interesting because diabetes insipidus, what that means is the person, it's due to either a medical issue or maybe medication. So if the person didn't have a medical condition, or they weren't taking a medication, they wouldn't have this diabetes insipidus. But a big one it's related to, that I'll talk about. You don't need to know central diabetes insipidus. That's more advanced. But what I'll say is, for people that have seizure disorders, severe seizure disorders, or they have bipolar and they take lithium, lithium toxicity and also lithium in general can lead to diabetes insipidus. And so what that means is if they pull them off of the lithium, the diabetes goes away. It's only based on the fact that because they're taking that lithium that it occurs. And so sometimes people have to have lithium. They have to take it. It's the only way that they can control their grand mal seizures, or the only way that they can control bipolar. And then what happens is these people will have to go on insulin maybe, or medications. It's very difficult because of the medication to control it with just diet and exercise. So sometimes they have to go on meds or even insulin. So that's what diabetes insipidus means. Now, with the adrenal cortex, this again, remember when I said think of corticosteroids when you're thinking about your pituitary and your corticotropins. And I said it's related to stress, and stress is related to the adrenal system. Well, the adrenal cortex, or your adrenal glands, are located on top of each kidney. So you have one on the left kidney and one on top of the right kidney. The adrenal cortex itself produces corticosteroids, or the steroid hormone. Now, if I say corticotropins, you're going to go back and go, okay, that's what the pituitary is releasing. But the adrenal cortex is releasing itself corticosteroids, or steroid hormone. Corticosteroids are important in our body because it helps control inflammation. It helps protect our body from getting sick. Corticosteroids are also involved with regulating carbohydrates and fat metabolism. So people with thyroid issues can also have issues with their corticosteroids, and vice versa. So because again, endocrine system is all related and it's all connected. So if you think about if you've ever had to take a drug like prednisone, or they say, I'm putting you on steroids, that's because you have some sort of inflammation. Sometimes people with bee stings or certain stings, they have to take a corticosteroid to reduce the inflammation. Sometimes people that have inflammation within their body, maybe a specific structure, maybe inflammation of the heart muscle, or inflammation of, the lungs or something, due to being sick. they oftentimes will be put on a regimen of corticosteroids because they want to bring down that inflammation. So prednisone, corticosteroids are good, or the prescribed like prednisone, corticosteroids are good, but only in small doses. Because over time, when people take these, especially in larger doses, they will crave carbs. They will crave and eat a lot. And as you can see, they're going to have difficulty with regulating that and they're going to gain weight. So, corticosteroids long term, not from what we produce in our body, that's good, but unless it's too much or too little. But if somebody takes over the prescribed corticosteroids like prednisone for a long period of time, that can really have hard effects on the body. So that's why you often see, if you've ever had to take a corticosteroid, they oftentimes come in packs where you take 6 one day and then 5 the next day and 4 the next day and 3 the next day and 2, because you can't just stop them. You have to, once you take a nice big dose, you have to slowly taper off because it can affect the body. So that is corticosteroids. So what happens if we produce too little corticosteroids? That's what's called Addison's disease. Addison's disease is an underproduction or low level, it's hypoadrenalism. It's a low level of production of corticosteroids. People will have abdominal pain. They'll be very weak. They'll get very significant low blood pressure, and that can be dangerous. You can die from that. Irritability, depression, apathy. Apathy meaning they don't care. They're just like, about everything. Anxiety, changes in personality or mood. So oftentimes, again, we got to rule out medical, but somebody may have Addison's and they're being diagnosed with personality disorders, mood disorders like depression, anxiety. It could be very, very, you know, bad for them to get these diagnoses, some of these diagnoses. So with Addison's, it can affect the mind with depression, apathy, anxiety, changes, big switches in personality, mood. And so once they get that stabilized with medication, then you'll see that depression go away. You'll see that anxiety go away, that change in personality or mood that will go away because it's related to the medical disorder of Addison's. Now, Cushing's is the opposite. It's hyper or high, what they call cortisolism. Okay, so overproduction of corticosteroids. So what you'll see, and you see this a lot in animals too, dogs especially, you may have heard with Cushing's or they're ruling out Cushing's. They'll get like a fatty hump between their shoulders, people in general, dogs. Their face will swell up, their neck will swell up. They may have high blood pressure, so it's high, so the blood pressure is going to go up. Diabetes can happen, bone loss, insomnia, decreased libido, impotence, depression, euphoria. Some people can get hallucinations, delusions, anxiety. So again, we have to rule out potential Cushing's when we see some of these, depression or hallucinations, illusions, anxiety, because otherwise we're going to treat something that isn't going to be treatable. In the psychology realm, we have to look and see if this is an issue. Now, when we're looking again at Cushing's, it's opposite. So it's hypercortisolism. So cortisol, as you remember, you learned earlier this semester, is related to stress, right? So it's going to help regulate stress. So cortisol is one of the hormones that is released by the adrenal cortex to help us with managing stress, anxiety, etc. So if it's too high, that can cause depression. It could cause anxiety. It could go either way, even euphoria. Because if you've ever taken a corticosteroid like prednisone in a higher dose, you can feel euphoric. So higher levels on our own, Cushing's, they could experience that as well. Whereas again, with Addison's, going back, the hypoadrenalism, there's low levels of corticosteroids, especially cortisol. So they may also be often high levels for getting sick. So we need a balance. Now, with the pineal body, the pineal gland is actually located in the midbrain. So in the midbrain, we have the pineal gland. One of the big things the pineal gland is important for is melatonin. So you hear people that have difficulty with sleeping, falling asleep, staying asleep, or during the day they tend to feel more drowsy. That could be one, sleep apnea, but that could also be melatonin. And so you often hear people say, oh, I'm taking melatonin to help with sleep, and it helps. And that often tells us that they have a little less melatonin than what they need. So we can get melatonin a lot from the sun, because it does. It's very much related. It's going to help us know when to sleep, when to wake. So again, people with low levels, we'll talk about that shortly, but they will tend to be sleepy during the day. They may be awake at night, like their sleep-wake cycle is completely messed up. So know that the pineal gland is located in the midbrain. It secretes melatonin, and that's going to help us regulate the sleep-wake cycle. Now, what if we have too much melatonin? That can be related to seasonal affective disorder, where, because again, if you think of sleep-wake cycle, well, when the weather changes, it can affect that. Excessive melatonin can lower blood pressure. It could decrease thyroid functioning. It can lead to depression, decrease that estrogen progesterone ratio. So that would be excessive. Under secretion could be insomnia. It could be psychosis. It could be mood dysregulation. It could be anxiety. So people want to make sure that their melatonin is balanced. So again, a lot of people will say, oh, melatonin will help you sleep. Well, you want to be careful if you're going and buying it over the counter and taking it, because it could affect depression. It could affect your blood pressure. It could affect your thyroid. So you want to be careful with that. So that is the end of what I want to focus on for this lecture. So again, remembering that what the pituitary secretes is not what the actual thyroid or the pancreas or whatever is secreting those glands. It's going to release those hormones that target specifically the organs and say, hey, thyroid, hey, pineal, hey, pancreas, whatever it is, I need you to release what you hold. Okay, so they're two different things. Hopefully I've made that clear in this lecture. And if not, go back, watch this again, and whatnot. So for the quiz, a lot of this is you'll see on the quiz. I try to make it 50-50 between the reading and the lecture, but the lectures are really important. So you're going to want to know if I say something like patient A is sensitive to heat, they're very anxious, they are have very dry skin, something like that, or if a person has low or non-secreting insulin, what organ is that related to? So it's going to be straightforward. So make your study cards, and you'll be okay. I'm not going to try to trick you. I want you to do well. So know the differences between the hyper and the hypo of the different glands, and know the hormones related to the glands and the hormones related to the pituitary. Okay, so if you have any questions, let me know. Other than that, have a good weekend and study well, and I hope you all do well. And I will talk to you in our next lecture. Okay, take care. Bye bye.